Hello, everybody, and welcome to episode 7. So today we're going to jump in with some common questions related to E&M services. This is something we'll probably play around with quite a bit just because, questions come in quite often. So Michelle is going to act as our moderator today, and she will also be giving her input as well. But we're going to jump right into the common questions that we are receiving, or I should say that I'm receiving, and just talk through different solutions. So Michelle, go ahead and start with the first one.
So the first question is, what level of risk does advanced imaging fall under? So I'm assuming this is
Okay.
column 3 on the MDM table of risk.
Yeah, so this is something that, I've been asked this recently, actually, a couple of times, and we have to think back to the fact that the 95-97 guidelines and that risk table does not exist, and everything didn't transfer into 2021 with the 2023 revisions. So what ends up happening is, first of all, from an imaging perspective, advanced imaging is looked at the same way as all of the other radiology that we are evaluating from a data perspective. So when we're in the middle column and we're looking at data, remember we have to look at whether or not that is going to be internal testing. And that goes back to the fact that we have internal tests that are already being reimbursed for typically the technical fee and professional fee if they're also doing the interpretation. And when we look at that, there's no direction that advanced imaging is higher risk, or when we think about the fact that contrast is used. I get asked that a lot as well, because previously we would look at contrast as a higher level of risk. But again, that did not transfer either into the new set of guidelines. So with imaging, we're sticking to understanding whether it's internal or external. And if we can give credit for things like the order, maybe a review of external imaging, or an interpretation that was originally done by someone external as well. In addition to that, and Michelle, this is something that brings in some subjectivity because, again, we're working with things that are guidelines. So we have to remember, and a lot get nervous with this, and a lot of providers don't necessarily want to hear this part of it, but because it's guidelines, we have some framework, but it's not all inclusive, right?
Yeah.
So when I'm asked this question about the third column, where my mind goes is related to more so a procedure, which maybe this isn't the way everyone would look at it, but when we think at different options in that third column, we look at things like a diagnostic procedure. There's different screenings that are done with scopes that are considered procedures. And we are then stuck into these buckets related to global periods, which obviously imaging, we don't have any global periods. So my question would be, in that situation, if we really dive out and, get out into this outer area where we don't have guidance, my question would be, what is the documentation showing about the fact that the patient needs that imaging done? So what I mean by that is, this is not something that would exist for everybody across the board. And that's the same concept we apply with procedures. We look at the procedure risk that is there for everyone having that performed, and then we look to patient personal risks. So my question would be, is there a concern for the patient based on maybe a known allergy or something like that, that in that moment is a concern that changes the thought process, changes decisions, things like that. I've not yet seen that, because all we ever see is an order for the imaging and
Yes.
contracts or whatever. I would not educate across the board that way. That's going to get very tricky because, like I said, there's a difference between, that contrast being a higher risk for everyone versus something that the patient has personally.
Yeah.
Uh, so I usually stick it in the data bucket in the middle, and there's not much more we can do from there. If anything, if you want to look to the third column, maybe we could argue low risk, but we don't really have any backing to support moderate, which is usually why I'm being asked that question.
Hmm.
Do you have any thoughts on that one?
I'm pretty much on the same page as you are. I would expect to see if the patient is at increased risk. I think of like contrast, a patient with chronic kidney disease. I would expect to see the provider linking those two together. Um, Showing that the patient's at increased risk for this imaging with contrast due to their chronic kidney disease. Um, we would expect to see that in documentation and not leave that up to assumption. Don't leave that specific individual risk up to assumption just because a condition exists in addition to this order. You want to make sure that you are linking that through documentation because some may not see it as a risk with a specific condition, but that's one that comes to mind specifically that would be patient specific, and you would want to link that, like I said. So kind of keeping in the same area of data, this is one where I personally get this question a lot, and I know in my work this is a source of rebuttal on quite a regular basis. But you had talked a little bit about reviewing the, external data and things like that and counting that in that middle column for data analyzed. What are the steps that you take? And I can go over the steps that I take as well when you're auditing review of external data in the medical record.
Yeah, so I'm assuming that this is asking the question related to an external review of notes or maybe even testing.
Yes, testing and notes.
Okay. So, first of all, the documentation has to be very clear, and this is usually what is deficient. So, what I mean by that is we can't know as a reviewer if we're able to give credit for that if we don't know a time frame. So,
Mhm.
a lot of times there's focus on the external component. I'll see a lot of providers saying, outside imaging was reviewed, or different language, maybe even saying the name of that outside organization or whatever it may be. So we can see the external component, but we can't always see a time frame. And that's
Mhm.
important because we have to remember that we can only give credit for that one time, even into the future. So if a provider says that they reviewed a chest x-ray today, how am I going to know when that was done if they in the future are looking at it again for comparison, if they're trying to get credit for the same thing? And, this is something too where it's based on review. It's not like our thought process behind what we're assigning is in there. If we were real time coding, it's not like that's going to be listed right there, in from that perspective. So
Mhm.
we have to be careful and make sure that we have proper instruction related to documentation. I educate on that every single time I teach E&M, and I still have a hard time unless it's something where the patient had a recent event, then it's very clear. So, for
Mhm.
example, if they say, I'm following up with the patient today after discharge or after an ER visit, then we've got a timeline. But outside of that, it's really difficult to be able to tell what's going on.
Yeah, I agree. And oftentimes I find that the review that is documented actually doesn't support data analyzed. So the specific steps that I take before I am assigning credit for review of tests is I actually go outside of the chart that I'm auditing and I look back at the previous encounters with that provider. I'm looking for, did they order this test themselves? Because we would not give credit for review if this was a test that they ordered at a previous encounter. And then I also am looking to see, have they reviewed this test at a previous encounter? Um, a lot of times the things that I am seeing documented as reviewed in the patient's medical record has either been ordered by that provider previously or previously reviewed, and you can't give credit in those instances. And this is an area where I receive a lot of pushback from people because they haven't taken the coders that I am auditing haven't taken the time to take that additional step and go back and see what has been reviewed to really truly validate if this can be supported as review of data. The other thing that I see is, like you had mentioned, they're being seen for hospital follow up and they're wanting to take credit for each additional thing. But when we're reviewing records from one unique source, that counts as one item analyzed, not each
Good
individual
point.
thing that is being reviewed. That hospitalization record is review of notes from one unique source. And so I think that a lot of times those definitions that AMA has given us, we're not taking that extra step to make sure that we are making sure these items meet those definitions that have been put forth for us, and they're very clear in the guidelines for us, which I really appreciate because it hasn't always been the case that we've been given such clear direction. The
Well, and
other
real quick on that, Michelle, that is a really good point because I've actually have had some sessions recently where I joined to do the education, and they think that they're right in the coding, meaning usually the providers, because they look at only the grid and they don't realize that AMA has, I think it's a 42-page document full of our actual guidelines we're given, the
Yes.
definitions, it fills in the blanks. So a lot of confusion comes for data comes from the fact that not everybody knows to look at the document. So yeah, that's a really good point about the definitions.
Yes, and I would say if you are a coder or auditor listening or a provider listening to this today, and you have not looked through, read through those guidelines, that's something you need to do ASAP. There are so many definitions in there that provide clarity to these things that we are often having questioned, and it would just be answered for you within those guidelines. So I highly recommend even doing a re-review if it's been a while since you have reviewed those guidelines. But I know for myself personally, as I'm auditing and formulating my audit comments, I really like to use the language from the guidelines because it's a little bit more of a definitive source than me saying I feel. It takes them back to that source document where I'm getting, where I'm making my decisions from. So definitely go read through those definitions, read through those guidelines. I think that data analyzed is one of the most um, understood sections of the table of risk. I don't know about you, Stephanie, but that's where there seems to be a lot of back and forth for me on what's considered data analyzed and what is not. The last thing on data analyzed that I want to point out is the documentation should be showing what the review of that tests is contributing on that date. So don't just go in there and say, chart reviewed. The chart was quite
Labs reviewed.
extensive. I had an audit the other day where the provider was saying, I reviewed the chart. It was quite extensive. Well, that's great that it was extensive, but what did that chart review do for you? That's not something that gives me any idea of what you did with that information. So make sure that one, it's not just a list of blown in labs. I know in Epic, their template that they have for notes pulls in all the recent labs. What does that even do or mean if they're not telling us what they're using that information for?
Yeah. And that's where there's a big difference too between the clinical side and also compliance and coding. And
Hmm.
that's a lot of times what we have to work through from, an education standpoint to get them to understand, okay, yes, that's there for clinical information,
Hmm.
but it's not usable from a coding perspective unless they give additional detail.
Yes. So moving on to the next question, and you ever so very slightly hinted on this with your when we were talking about that advanced imaging, but there is a lot of confusion around what is considered a major versus a minor procedure. So do you want to talk a little bit about that, about what the AMA says, what CMS says, and what you specifically audit to?
Yep. So, first, we have to recognize that AMA does tell us that they never intended the global periods to dictate minor versus major procedures. But the caveat here that we have to remember is that AMA is not the entity that reimburses the claims. So, for that reason, yes, we do look at AMA. I always say AMA is absolutely our foundation level, right? We're
Hmm.
going to look at them for the guidance based on, how the codes are written, what the descriptions are, the guidelines, everything we've got in writing from them. Then we have to look to payers. And when payers are more specific than AMA, we have to follow that guidance, whether we like it or not, because they're the ones reimbursing the claim. So, with that being said, if you go into CMS's NCCI manual, it specifically states that the surgeries or the procedures are based on global period. So, anything that has a 0 to 10 day global period is going to be minor. Anything that has a 90-day global period will be major. Now, sometimes I work with organizations that's a real frustration point for them, and depending on specialty. Michelle, with GI, for example, they're doing entire scope procedures, putting a patient under anesthesia, and they're still considered to be 0 day global periods. Or when we're working with pain management and they're doing an
Hmm.
injection into the spinal column, in that situation, that risk from, remember, a coding perspective is the same as the risk with a joint injection.
Hmm.
So we have to again remember that we've got to talk through clinical, but then apply the coding. And this is something where sometimes organizations are wanting to make a decision based on the answer they like more than the other. But we
Yes.
have to recognize the fact that when the payers are more strict, we don't have an option but to follow the payer, because that's what you're going to be audited up against externally. So we
Hmm.
need to make sure that when we have that guidance, we're aware of it. And one step further, sometimes I'm asked, why would we look to CMS when that's a small portion? We don't have all Medicare patients, for example. But the answer to that is if you dig into the information from the commercial payer side, they also default in to CMS. So if they don't have guidance, for example, then in that situation, we're going to have a problem, because what's going to be done, and internally they're defaulting to CMS, but it's not publicly on a site. One of the areas you can go to look into that a little more if you want to see that link is typically in the provide or participating provider manuals. There will be language in there related to their following of CMS policies. But this is why, from this perspective, when we're doing things from an educational perspective, we need to be open to these conversations, because we're not saying it just to limit, leveling of service. There's a very real reason with resources behind it as to why that has to be followed.
Hmm. Yeah. And I think that when I get pushback on this, they the provider or the auditor is expecting you to just know based on the name of the procedure being performed why this is at higher risk. And even AMA, in they have a FAQ for E&M. I was reading about this, and even AMA is saying that it's up to the provider to identify it as a major or minor procedure. And when I'm coming up
And
against this,
1 second, Michelle, that doesn't mean that they get to ultimately decide and their decision is the end all be all. I
correct.
think they were meaning in documentation, what are they showing us about the risk?
Yes, exactly. And that's my point. That's what's deficient in the documentation, because they're not saying what the risk is that makes this minor procedure more risky. For example, they're just expecting you to see the name of the procedure and say, oh, this is a risky procedure. This should be considered a major procedure. And from a coding and auditing perspective, that would definitely be a clinical interpretation, should that not be specified by our provider. And it's also something that should be noted that not every procedure across the board should be identified as a major procedure, even when they have those, you're talking about pain management. And I think of like a cardiac cath and things like that. It's, it would be up to the provider, but ultimately for myself, how I educate, how I respond in my audits and my audit findings, I follow the CMS guidance, as you said, on the major versus minor procedure being based on the global days, even though AMA specifically says that's not how it's determined.
Yep.
All right. So for the next question, what is the difference between acute uncomplicated and acute complicated?
Yeah, so I had actually, there was a lot of engagement as well. I get asked this question a lot, and I had done a LinkedIn post. I think I wrote an article. I can't, I should remember. I think
Yeah.
there's an article out there. Yes, there's an article. Um, but this is something that comes up often, and I had a couple of really good follow-up questions based on the LinkedIn post. And someone was asking, for example, why do I reference acute complicated when if we look only at the grid or, some of the language in the guidelines as well, but it says complicated injury. So,
Hmm.
one of the things I want to point to first is the fact that when we look at the systemic symptoms, which would be acute with systemic symptoms, which is at the moderate level. When we also look to the unknown component, so unknown diagnosis, unknown outcome with that prognosis, those are pointing to complicated situations.
Hmm.
So this is one of the things too that people sometimes really struggle with. Again, these are guidelines. We can't stick only to the wording and the bullet points there, or it's not going to fit into every different scenario we come across. Not only do we have a lot of different scenarios that we deal with, but we also have to apply it to documentation, which adds a whole other level of complexity depending on
Hmm.
the detail we have there. With that being said, what points to complicated is when we look at, for example, patients who have a systemic symptom. AMA even says in there that we're not automatically able to give moderate complexity for every patient who has a systemic symptom. And
Yes.
one of the ones we see a lot, especially in pediatrics, are patients coming in with a fever. There's so many times I've audited pediatrics since the new set of guidelines came out, and almost everything's a 4, and it's like, why are we heavy on the 4s? And you look in there and they're misunderstanding systemic symptoms.
Hmm.
This is another one too, to your point before, where we do have more clarification from AMA, where they've stated essentially if that symptom is expected to resolve itself and not become, it's not a higher risk at that moment, then if the normal course of treatment is going to resolve that, that is a low risk systemic symptom, not a moderate risk.
Hmm.
So overall, what we're looking at is the risk to the patient from more so that outcome standpoint. So one, the question is there a concern here and now today? Remember, E&M coding is not about what is to come in the future. It's about how that patient has presented, how they are
Hmm.
in the practice that day. it's up to the practitioner and the provider to add free texted documentation for us to be able to see what their concern is and what is playing into the complexity of that patient. So it really goes back to what you said before, Michelle, with assumptions. That's a
Mhm.
huge part of what we do, whether we're coding or auditing. We're never making an assumption based on a diagnosis, a symptom, an age of a patient. We hear that
Mhm.
all of the time in pediatrics. The argument is that, a fever in a younger child means something much different than, an older child. We have to see that because we cannot make these clinical assumptions for our practitioners. And, this is another reason why it's so important to have external audits done for internal improvement purposes, because we have, this cadence where everyone gets comfortable, familiar with what the providers are doing, with what they're documenting. And by default, sometimes from internal pressure, which is not
Mhm.
fair, but it happens, they will code a certain way because they assume they know what's going on, and we can't be doing that.
Yes, exactly. And I think this is also where that constant um it keeps coming back to when we're talking to providers, explain your thought process. That's all you have to do typically is explain your thought process. Why are you ordering these additional tests? What are you looking for in this additional testing? um, Explain your thought process. If you're putting the patient on a steroid and they have diabetes, just explain very briefly why that places them at increased risk, or show through your documentation how you're instructing your patient to do additional monitoring of their blood sugar and things like that. It's just a matter of showing your thought process. And so so many times I feel like the assumptions are made, like you said, whether it be just from getting comfortable. um, as coders and auditors, a lot of times we do understand the clinical processes behind certain conditions and things like that, which can sometimes cause us to go over that boundary of making clinical interpretations or assumptions from within the medical record. I know I'm guilty of it myself. But we have to be really vigilant to make sure that the documentation is showing us that increased risk, and we're not just assuming it based on, like you said, the presence of a diagnosis and age, and things like that. If there's nothing showing the complicating factors why this is not expected to resolve with the normal course of treatment, what the provider feels is hindering the resolution of the problem or causing progression of the problem, then we don't have the documentation to support that as a complicated injury or illness.
Yep, I agree.
Okay, so the next one, this is a column 3 item. And is there a list of drugs that automatically fall under that category of drug therapy requiring intensive monitoring for toxicity?
Yeah, so this was a great question. And what this comes down to, again, even if there is a list doesn't matter. The
Hmm.
reason that I say that is the documentation would have to support it at the time that the tests are being ordered. And this is something that really needs clarification as well, because I have seen misunderstanding through education sessions with the various groups I'm working with, where the practitioners were thinking, okay, my examination is actually how I'm looking for toxic effects of a medication. But the guidelines do specifically state, first of all, intensive means that the orders are done at least once a quarter, very clearly orders for testing. It doesn't
Hmm.
have to be a lab test. Sometimes radiology, like an ultrasound, could be used for that toxic effect. But remember, they're looking at a very specific organ system to see if that medication is having a negative effect on organ systems just based on potential complications of drugs. So, for example, I work a lot with rheumatologists, and there are a lot of high risk medications, and they're following the renal function, or
Mhm.
sometimes with different medications, they need to follow the liver function. Now, when I see that lab test being ordered at that follow up visit, I cannot automatically give credit for monitoring of toxicity because they're looking at renal function. The note would have to actually state at the time of the order that the indication for that test is looking for toxicity. This is another thing that there's been a lot of misunderstanding. I don't really
Mhm.
think we're there yet from a documentation standpoint. A lot of the rheumatologists that I work with are starting to add that in, but when I work with people initially, it's something that I'm typically finding is deficient, and we don't have enough detail again to give credit for that
Mhm.
toxicity.
Yeah, I agree. A lot of times I get these responses like, "But the patient is on this medication." And it's like, "Well, that's what does that mean? You got to
Yeah.
tell us, explain your thought process. Why did you order this testing? Why are you doing this, monitoring?" And like you said, that's often what's deficient, but there is no elusive list out there that if the patient is on this drug, it supports high complexity. Um, in my earlier years of coding, I was showed a list such as this, and I never really understood. Okay, that's great, but why? Why is it high risk? And oftentimes, that's what's missing is the why in the note, and not the actual drug, but the why.
Yeah, and sometimes too, so this is a different conversation within the third column for risk, but we do have the options now to look at with one of the revisions and updates. AMA clarified we can look at high risk medication like a narcotic that is given
Hmm.
through an IV, but that's a much different situation. With toxicity, we're not looking at medications. Obviously, with certain medications, the side effects will impact organ systems, but
Hmm.
that's not our place to decide. And just like the fact the patient takes some medication does not always count in every encounter if we cannot see how it's managed, same exact thing applies here. If we don't see the reference to the toxicity, to the monitoring, we're not able to link that together for our providers.
Hmm. Yes. So next question here, and I think that this is something that both of us have been seeing quite a bit of lately and getting asked questions about quite a bit. But do all diagnosis documented in the assessment and plan count as a problem addressed? Now, I'll give you an example of what I have been seeing lately. And it's that documentation style where they have a list of diagnoses documented in the assessment and plan, and then they have um, a plan document out. So it's not really a true assessment, in my opinion. They're listing a problem list, and then they have a plan. But
Yeah.
what is your response or your recommendations on or your thoughts on this?
Yeah, so one of the things with this, we have to remember the definition or the intent of an assessment has changed over time with the use of an EMR system. So what I mean by that is the assessment is intended to be the perspective of that treating practitioner on that day. So from their perspective, what is the stability level? What concerns do
Mhm.
they have? What is the severity of the condition? But with the EMR system, when you look at it from a user perspective, a lot of times it just has the practitioner going in and selecting all of the diagnoses, which is then defaulting ICD-10 codes and descriptions. So we don't have their actual thought process. And there are times that systems allow a provider to add other information, like free texted, to the side of that defaulted diagnosis. But a lot of times, what ends up happening is we have the separate treatment plan underneath.
Mhm.
And I think that there's multiple different reasons I think this is happening and it's a problem. But one of the big ones is related to risk adjustment. It's
Mhm.
like, how many times do we go out there or you hear of organizations who are a part of an ACO? Maybe their Medicare Advantage plans are really getting on their backs and they're saying that they're not staying on top of it. Um, there's all that pressure from that side of what is done in the industry with risk adjustment that, think about it this way as well. And I always like to emphasize this because what we do from the compliance side of the industry as it relates to documentation and coding, we're like that irritating person over here saying, we need more, right?
Mhm.
We're not
Yes.
the ones there saying, oh, forget about this, take good care of the patients. That is what our providers want to do. And it's a good thing that they want to do that. That's why they went to school. They didn't go to become a doctor or an APP to sit here and listen to us talk about coding and
Yes.
documentation and, oh, we need this for billing. So we have to keep that in mind when we go to this extent and think through to this level because it's just one more ask. But with that being said, risk adjustment is becoming this other pressure point, right? Because they're
Yes.
being told, capture every diagnosis, be as specific as possible. But then they've got a large, schedule. They're seeing lots of patients back to back. Then they've got to figure out how to complete their notes. A lot of organizations are no longer employing coders. There's
Mhm.
even different hospital facilities that don't have coders for providers. So it's putting the weight of that on their back, and it's just one more thing. So I say all of that because when this is found on a review, we have to trace it back to see what the root cause is. So sometimes, and I know you've seen this, Michelle, in
Mhm.
different EMR systems, they have options in there that allow a provider to click a button and it'll default basically the problem list. The
Mhm.
diagnoses that are still showing as active for the patient in general in their chart will go in. And for them, they're looking at it from that workflow. Okay, this is easy. I can blow my list in. I'll just fill out what was relevant. And they think, oh, I met the metric, because I showed that this is something in the assessment today that should be counted.
Yeah.
So there's a lot of deficiencies out there where people are not really letting their providers understand that side of the industry. And if you think about it as well from the perspective of the fact that a lot of risk adjustment occurs behind the scenes, meaning
Mhm.
that if they are participating in managed plans or other commercial plans that are using their claims data in that way, they don't know really what's going on. It's not their fee for service. They're not getting monies back initially and immediately. So it's not always something they even know is happening in the background with their information.
Yeah.
So it's a huge problem, but there's also a lot of deficiencies in proper education and support for our providers. And we've got to get into these EMR systems and get that taken out. That button is just so frustrating to me because on
Mhm.
the compliance side, it is absolutely useless and all it does is hurt the process. Whether they're
Yes.
using it for an order or they're using it towards their current date of service, it's problematic. One last thing I will say, I met with one of my clients a couple weeks ago, and they had let me know that their EMR that did previously only have an option to default all active conditions had added a new button in there that they could click that our diagnosis is relevant to that encounter. Now, that is what would, kind of spill over into some of the ordering that they put in. But
Mhm.
those are the types of things that need to be addressed because ongoing lists always end up into our claims system because again whatever they're putting into their assessment and plan is going to flow into the practice management system and end up in charge entry. So
Yes.
a lot of things that have to happen there, and I would say a lot of it is surrounding the provider that other people need to be looking at solutions for. And
Yes.
ultimately meeting with the provider, but that one's not on the provider's back by
No.
themselves.
And one thing that I will say, my really only soapbox item on this topic is that the criteria for HCC does not automatically consider that diagnosis to be a problem addressed at the encounter.
Yep.
Those are two completely separate things. And for it to be a problem addressed, we have to see that documentation brought full circle by the provider. How did they take that information and then assess, and address that particular condition? What did they do with it? And a lot of times, the questions I'll get, or the pushback that I'll get is, well, it's documented in the HPI, and it's like, well, this is clearly from the patient's perspective. What did the provider do with that today? Or, they're pulling from other parts in the note, but there's nothing showing how the provider brought that full circle to make it that problem addressed. So HCC does not automatically mean problem addressed. And I think that we need to normalize separating those two
Well,
when
and
we are coding and auditing.
to that point, I actually think it's interesting you say this because I had someone get pretty upset with me once when I was teaching a session and I brought up AMA's definition of problem addressed towards E&M in our first column of MDM. And in there, they specifically say, just like you're saying, what did the provider do personally to address it? And I actually think that there is a line between the two, because when we think about our risk adjustment side, we need to know how they're personally managing it, how they're monitoring it, or how it impacted the decisions they made that day. So that really is the same exact thing you're saying. It's just
Hmm.
used in two different ways. So
True. Yes.
that is one way that you can use that to work with your providers from an education standpoint, is that those two are not that far off. And if you can't be bringing it in for this purpose, we shouldn't see it for the other.
Hmm.
But there's a lot to do from the education point, because a lot of people have not even gotten their providers to that point. So
Yeah, I agree that it it a lot of times is a workflow issue when we're seeing that in documentation. Do we have time for one more?
yes, so we'll do one more quick and then we'll end the episode.
Okay, so this I think is something we get asked more from providers than we do coders and auditors. But um, if the nature of the presenting problem supports a higher level of service than total time or MDM, can a higher level of service be reported?
So, a couple of things. And the first thing that came to my mind, and I think what's being asked, is if our presenting problem ends up a higher level of risk on our grid, but we don't overall level out at that.
Hmm.
So, for example, let's say our presenting problem would support, and I get this one a lot. So I'll read in the documentation that the patient is really struggling when they come in. They have a severe exacerbation of their problem. This can happen a lot, especially in like orthopedics, definitely with rheumatology. They're experiencing a lot of pain. It's, causing a lot of issues for them in their daily life. The note does a great job looking at the severity of the condition, but then the outcome from a treatment perspective is managing the medication,
Hmm.
which we know is down at the moderate level. So that's something we still need to work on in education, because previously when we would try to apply that subjective concept of overall medical necessity and severity in E&M, we would heavily look at and weight the presenting problems towards a level of service. But
Hmm.
now it's one half of our equation, right? So we
Yeah.
may have high with the one, but we don't have it in any other area, so we can't go up to that level. So we still have to be following our concept of 2 out of 3. One thing I do want to say as well that I came across that's a little similar but different recently is when organizations are allowing a provider to choose between time or MDM and stick to whichever one they want, regardless of what supports a higher level. And that
Mhm.
is a problem. That's a big issue. When we look at different things, ultimately the False Claims Act and what that's referring to, we have to make sure there is accuracy in coding and allowing, regular defaulting to one area so they don't have to think about everything that goes into coding is not going to be appropriate.
Mhm.
I'll finish this out here really quick, Michelle, with a funny story. So I had been through a really long education session. Again, I am fully aware that providers definitely don't want to be sitting through sessions with me. Some of them are very engaged, but most are not. They're frustrated and they're annoyed. And I finish out an hour and a half session pretty much. And one of the physician asks a question and says, "So can I just bill on time and forget everything you just said to us?" And it's like I just started laughing and blurted out, "No," because what kind of question is that? Like, no, that would be
Mhm.
nice. Yes, we're in a heavy regulated industry, but it's the way that it is, and we don't get to do that. We have to be aware of this whether you want to be or not. And hopefully people are getting to work with good support staff,
Mhm.
whether it's internal or external. That's something I always try to do with my clients when we're bringing all of these things in that are frustrating. We have to come to them with solutions, and we have to help them work through that solution in the best way possible to be as the least disruptive as possible. So there's so much, and I'm sure so many more we could get into, but we'll go
Yes,
ahead and end it there for today.
for
Um,
sure.
I do just want to mention quickly too, I've had it up on the screen during the episode here, but we do currently have the code going for the week. Just this week, it goes through Friday. The discount code Lucky in all caps, LUCKY. And that is good for 20% off of the annual version of the membership on our site on StephanieAllardConsulting.com. Just so to give you a quick overview, the membership does include regular access to me with things like this with Q&A. So if you
Mhm.
have regular questions for your group, maybe for you and your position personally, I'm happy to support with that. The turnaround time is within 24 business hours. So I'm happy to be there and support you in what you're working through. I do also have a lot of educational resources that are on there, some educational webinars, on demand webinars, and some different tools and things like that. We do also have different live events throughout the month. So we do live Q&A, so similar to this, but just for members. And we also do a mentorship. So there's a live Q&A for that side of things. If you're
Mhm.
looking at advancing in your career, getting some support, guidance, things like that. And we also have a professional book club. So that I'm excited about that part because that's my favorite geek hobby. I love to read. So pretty much in my free time, that's what I try to fit in is reading. But we're looking at that from the perspective of, improving our professional life to help the personal life.
Mhm.
So feel free to check that out on the website and
Yes.
hope to see you all at the next episode.
Yep, and just real quick, as somebody who is a member, who has the membership, I will say the access to Stephanie for your compliance questions alone is worth the price that of this membership. I think I utilize that. I probably utilize that more than anybody else. Uh, maybe you'll have to charge me double next year. But
No,
I highly recommend it because the resources and that access to Stephanie for your questions with her responses are always very thorough, easy to understand. She doesn't just give you yes or no, she explains her thought process. So it helps you kind of adjust your own thought process and implement that into the future as well.
All right, thank you. Have a good afternoon, everybody.
Bye.